All right. Hello, everybody. So this video is going to be how to survive your first day of anesthesia clinicals. Now, this is going to be catered specifically towards CAA students, as that's obviously my profession of choice. However, if you are an SRNA, an MD or a DO starting maybe not residency, but maybe I can't remember what it's called for you guys, but maybe it is called rotations for you as well. But the whole idea of this is to just kind of lay that groundwork so you can hit the ground running and start off on the best foot possible. I remember being very terrified for my very first day, and not for lack of knowledge, but just for lack of experience. I know induction drugs. I guess I knew induction drugs. I knew patient positioning. I knew the flow of things. I knew how to go through all of the processes. I had just never actually done it. And the OR was a somewhat familiar environment for me. I was an anesthesia tech, but it's going to be very different no matter where you go. So I wanted to go ahead and make this to hopefully help you guys out. So this is at least what I wish I knew going into this. If there is something that has some level or layer of subjectivity, I'm going to try to highlight that. But I highly suggest you watch this video before your very first day of in-hospital anesthesia clinicals. Okay? So let's jump into it. So step one, you got to know what hospital you're going to. At least for us at NSU, we got assigned our hospital. So a few questions you should think about is, are you going to an academic institution? What's the general layout of the hospital? What types of cases might you see? And then what will your preceptors be? MDs, DOs, CAAs, CRNAs. Now, the reason why you care if it's an academic institution, if it's an academic institution, it's more than likely, or it really is, a teaching hospital. So if you're going to well-renowned teaching hospital, they're going to care less about waste. And what I mean by that is if you open a tool, so let's just say you open an oral airway and a nasal airway, the teaching hospital will care less about that than a for-profit hospital. Do I suggest you waste things willy-nilly? Of course not, but they are going to be a little bit more lenient up front when it comes to that sort of thing. It also means the pace might be a little bit slower, so you can take your time going through the induction process. I recommend still going ahead and building up speed and getting better over time, but it means you have more breathing room, typically. What is the general layout of the hospital? Some hospitals have one main campus. Some hospitals have a main campus, a side campus, and then like 2 satellites. So that's something you have to figure out as well. And parking is something I stress out about. You might not stress out about it at all, but it's something that I stress out about. So I always figured out parking almost up front. I would look at Google Maps and figure out, okay, I can probably park there. So at least had a general idea of if I'm about to park in one and it says patient only, all right, let me go to the backup one I saw. That's just something I worried about. Now, if your school is relatively close with the program or with the hospital, right? So for instance, if you got a hospital that's just right there, you always send students there, they're going to have it figured out, and you can ask a former classmate, or you can ask a professor even, hey, where do I park? Typically, they'll handle that for you, as in when you get your email, and that's going to show up on the next slide. But what types of cases might you see? Odds are, even if it's a level 1 trauma center, very first day, that's not going to be something you're going to have to see or help with. I'm not saying it's impossible, but I'm saying it's unlikely. Typically, the way these have gone for us is you start out in the more basic cases, think like lap chole, lap appy. You can even do like endoscopies, like colonoscopies. You can do EGDs, things like that, and kind of build up from there. Now, it's not impossible. I mean, my first day I had a pretty intense case, but to that end, my preceptor recognized that it was a little bit beyond my skill level, so they tried to kind of like slow things down a little bit for me and show me through the process better. So, and then what will your preceptors be? Mainly that matters for who you need to introduce yourself to. If you have a doctor, so a doctor, they don't have to answer to anybody, whereas a CAA specifically, and then maybe a CRNA, has to communicate with a doctor. So that's just something you have to think about as well. Might change the dynamic. It's impossible to judge somebody based purely on their title. They could be, just because their name has MD at the end of it on their jacket doesn't mean they're a good person, good preceptor, bad preceptor. Same thing for CRNA, same thing for CAA. I've had good and bad of both. Just something you want to think about because it mainly matters for who you have to talk to. But again, first day, take it easy, you'll be okay. And I'll get into all that a little bit later. So step 2, before the welcome day. So you need to prepare for the welcome day. Now, typically you'll hear about this over an email. It'll come to your school email, and it'll say, welcome to, this is our hospital, here's any paperwork you need, here's where our meeting is, here's what time to be there, right? Again, first thing I figure out is where's parking, because that's one thing that stresses me out. If it doesn't stress you out, then hey, good for you. Plan to wear business casual, and you may or may not need your white coat as well. School ID, it's a good idea to go ahead and bring that too. As for the very first, you don't need to do much build up into this, just have all the baselines answered in terms of, where's parking, who am I meeting, where am I meeting them, what time am I meeting there, stuff like that. As for what you need to figure out during the welcome day, that's what this slide is for. Now, I'm going to go ahead and hide my webcam. There we go. So during the welcome day, right, this is the tour of the hospital day. There are some questions you need to think about. Right, so where are the ORs? Where's pre-op and PACU? Where's the break room and locker room? Where is the main OR boards? Where or how are cases assigned? How does badge access work? How do you get and return scrubs? Will you be able to look up cases the night before? Is there some policy this hospital has that I need to pay special attention to? And where can I keep my packed lunch? So I'm going to move my cam over here. So, where are the ORs? Some of them have one central hub, and everything is based out of that one central hub. Other ones have little scattered parts, right? So you'll have main ORs, and then you'll have endoscopy over here, EP over here, and they'll each have their own pre-op and PACU. Again, it's expected that you're going to get lost on the first day, but it's a good idea to have a general idea. So if you walk in for a lap chole, that's going to be with the main ORs. But if you come in and you see, I've got 3 endoscopies, and I'm only doing endoscopies today, all right, you're going to be an endo. Versus, I'm going to be doing bronchoscopies. Where's that? If you already know it's going to be separate from the main ORs, you can at least go into it expecting that and have some base level idea. Pre-op and PACU, if a hospital has, endoscopy, bronchoscopy, and then EP all separated, odds are they're going to each have their own pre-op and PACU. Typically, they're in close proximity to each other, like pre-op and PACU are relatively close, as well as being close to the ORs themselves. Where's the break room? Where's the locker room? Those are going to be your 2 main hubs. Break room, you can find your preceptor there sometimes. Locker room, you need to go there to get changed. Main OR boards, this is kind of the central hub of the actual OR area typically. And this is where all of the cases are going to be listed. It'll say OR 1 through, however many. And you can look and see what's going on throughout the day. A lot of people will gather there, and sometimes your preceptor will say, hey, just meet me at the boards. And that's where you'll need to go for that. How are cases assigned? Some places will let you pick between certain preceptors. Some places you get assigned the morning of. Some places you get assigned the night before. Just good to go ahead and know how that works. Badge access, you might need it for doors, right? So case by case basis, some hospitals had it or you were given it. Some hospitals said you just got to wait or you got to ring this doorbell and go through that process. That's going to depend. Get and return scrubs should be pretty self-explanatory. Will you be able to look up cases the night before? Again, depends on where you're at. Some will let you, some won't let you. Just depends. But good to go ahead and figure that out. Is there some hospital policy that I need to pay special attention to? For instance, are shoe covers required? Or, are preceptors meant to get there even before you do? I don't know. Right? Just figure that out. Maybe there's some protocol they have to follow and you have to go along with it. So, just something you got to pay attention to. You'll figure that one out mainly after the welcome day. Uh, just something to keep in the back of your mind. Where can I keep my packed lunch? For the first day, I would just suggest bringing a packed lunch. Most places will have a cafeteria, but it'd be one more way for you to get lost. So I would suggest just bringing a packed lunch and figure out where you can store it. Typically in the break room or in a fridge somewhere. It's better safe than sorry, in my opinion. All right. Next up. So this is just kind of my personal advice, where during your introduction or welcome day, I always get so turned around because the person who's guiding us, knows the hospital like the back of their hand. And when you know how something works, you're not good at explaining it super well sometimes. And that's a huge hurdle for me. So here's what I would suggest, right? You can see my mouse, yep. So you obviously have figured out where parking is by this point. Two main hubs you're going to need to care about, right? You've got the locker room and the main ORs. So figure out this line right here. So figure out parking to locker room to main ORs. If you have that baseline, you can fill in everything else around it. Right, so parking, the locker room, main ORs. Once you're at the main ORs, then I would suggest finding the break room and the OR boards. Right, so I would just suggest this line and then this fork. Lunch, preceptor will take you there, tell you how it goes. And then other stuff, odds are, locker room's gonna have a bathroom, that'll cover that. If you try to start filling in all this extra stuff, like how do you go from, the bathrooms to the break room to lunch, if you try to make those off connections, you're going to end up confusing yourself on day one. So just figure out parking, locker room, main ORs, OR boards will be near the main ORs, and typically the break room is pretty close as well. That's my suggestion. Just figure out this. Like lunch to OR boards and all of this, like weird connections, that'll come with time. Just focus on the basics right now. Okay? That's all you need, I promise you. If you do get lost, talk to your preceptor. Now, if you can look up cases, don't overwhelm yourself. EMRs are very complicated in the sense of it's a new system to you, it's your first day. They might not even expect you to do it on your first day. But if you are going to go ahead and dip your toe, which I do suggest you try, here's what I would focus on. Height, weight, and then gender/sex, allergies, procedure being performed, comorbidities, you'll learn those more over time, and at-home medications. Again, you'll learn those more over time. Height, weight, gender, those matter for selecting things like oral airway sizing, for LMA sizing, and tracheal tube sizing. I didn't put age in here. Age also does matter. Age would matter for something like Versed. Allergies, self-explanatory. Procedure being performed. The procedure dictates the tools you need. Simple as that. If you're doing colonoscopies, well, you probably don't need an endotracheal tube and an LMA and all this other stuff. So that will kind of dictate what you get ready. Again, you'll learn that more over time. And I'll talk about that a little bit later. Comorbidities, if they've had a recent heart attack, if they have heart stents placed, if they're an asthmatic, if they've had a recent stroke, any number of things, and you'll learn them more over time and how they matter for the anesthetic plan. But just go ahead and have a good baseline idea. So if your preceptor happens to ask about it, you can say, oh yeah, they have COPD, and you can kind of impress them in that way. At-home medications, I've had patients come in on 0, and I have, no joke, had patients come in on 20. Now, even at my stage, I have 300 plus clinical hours at this point. I see that list, I get overwhelmed. Simple as that. Just, if you don't know what one is, just Google it real quick little cursory search, because you might not fully recognize what it is. If you Google it and it says seizure medication, well, that's really what you care about, and you kind of go through it like that. Common things you're going to see are going to be like diuretics for high blood pressure, you're going to see beta blockers, A lot of diabetes medications like metformin, might see like Wegovy, Ozempic, those GLP-1s. You might see some antibiotics for some people, depending on how long they've been there. Um, you're probably going to see like Tylenol, aspirin, all of those. You're probably going to see, depending on who it is, if they have chronic pain, you might see some opioids. Um, like I've seen, anywhere from like Dilaudid, uh, oxycodone, hydrocodone, any number of things you're going to see, but they typically break down into categories. Just take them at face value for first day and just go with the flow. You'll figure out over time what's expected of you. I do recommend you try to exceed expectations in that if you know you're going to a preceptor who doesn't expect you to look up cases, if you still go ahead and look up cases, you're giving yourself more practice. And when you start moving on and the expectations start to build up, you're going to want to have that experience already built in, right? So just stay ahead of the curve on that. Anyway, and not all places will let you look up cases. All right, webcam's going away again. There we go. So if the location wants you to reach out to preceptors, it's kind of up to you how you do it. You can either be super informative or very basic, and again, it's largely up to you. The key information you want to get: your name, your program, and if it is your first day, you want to say it is your first day. And you can also ask what they want you to get set up in the morning. People recognize that their hospital is different than the hospital across the street. It's just how it goes. So here's an example. Hello, my name is John Doe, and I'm a first year, CAA, CRNA, whatever student at this school. Tomorrow will be my first day in the OR as a student, and I am very excited to work with you. What would you suggest I set up in the morning? Now they might just say, oh, just set up an airway, or they might say airway and IV bag. I mean, any number of things, but at least you have a foundation you can build on. Now, if they say an airway, typically, I think I'll talk about this a little bit later, actually. Yeah, I do, so I'll get into it. Every location is going to be a little bit different. Just do your best to take it at face value. But you can also bounce questions off of them pretty easily. So, and again, you can also, I had a classmate he would just say, hey, this is my name, first year student, I'll see you tomorrow. Like, you can be super basic, or you can give them a paragraph. Typically, if you give them a paragraph, they might just skim it though. So you'll figure it out with time. All right, webcam's coming back. We can go right up here. There we go, perfect. So when to show up? Show up early for day one. You don't gotta be there 3 hours early, but you need to give yourself time. Right? I would always err on the side of giving myself too much time, because it's easier to start showing up later than having to, like, oh crap, I needed to show up earlier, I'm already late, and then I gotta deal with all that, my preceptor's mad, surgery's delayed, whatever. So keep that in mind. Always just show up early, because you can always just back off on it. So the way I did it, this was overkill. I would be parking at the hospital an hour and a half early. So if it was a 7:30 start, I was there at 6 a.m. Because I'm the type where I would get lost, I might park in the wrong place, I might not know where to find the glide scope or the McGrath, and that I needed to have a couple days there to know everything worked, and then I would start to back off on time. Typically, preceptors will get there about 30 minutes before a case start. That's not an exact time, that's just an approximate. So if you have a 7:30 start, odds are they'll be there at 7. So if you have enough time before then, you need to get changed, put away your lunch, you need to find your OR, you need to get everything all out and ready, go through the full MS maids. Just give yourself more time. The more you have done by the time they get there, the more impressed they'll be. Now, I'm not saying just start magically finding work, but just give yourself enough time where if you need to go slow because you haven't done a machine check in a little while, you can just go through the motions at your own pace and figure it out. Each place has different machines as well. The place I went for my first rotation and my current rotation have very different anesthesia machines. I walked into this new site, saw their machine, and had no idea where all the buttons were, how it all worked, or anything. But I built in enough time where I was able to figure that out and run through everything. So give yourself time. Now, let's go ahead and hide that again. Proper OR attire only beyond this point. You will likely see that sign somewhere. You might see like a red line across the floor, and on your welcome day they'll probably explain what that means. So basically means that beyond this line or beyond these doors or beyond this point, you need to be wearing proper OR attire. What does that mean? Not all of us have as much healthcare experience as the others, so what does that mean? It's going to vary, but generally it's scrub top, scrub bottom, a hairnet, or one of the cool hats everybody's wearing, and a face mask. Now, face masks generally don't need to be worn outside of ORs, and if you're really kind of sketched out about it, if you see a nurse wearing theirs, it's a safe bet to throw on yours as well. For your very first day, so first of all, face masks are kept outside of ORs. There's going to be a sink typically, and that's going to be the scrub sink where the surgeon and anybody like the scrub tech, assisting PA, they will all scrub in. There's going to be face masks right there typically, so that's where you can find them, is directly outside of ORs. So if you're at that point, you don't really need your mask because you can't have one by that point if they're sitting out, if that makes sense. Now, I would recommend whenever you go into any OR for your first day, just go ahead and throw it on there. If there is nothing laid out, you're the only one there, you're there an hour and a half early, just go ahead and throw it on, and you'll figure out when is a good time. Just err on the side of caution for now. It's a lot easier that way than somebody yelling at you because you broke sterility. And another thing to think about is sometimes they want you to go in through the sub-sterile. It's typically a door to the side. Let me turn on my webcam. So if this is your main OR, right, here are your double doors, typically the sub-sterile doors are a little bit off to the side and they connect back into the OR. And if you go into sub-sterile, go ahead and have that mask on. The places that will need or want you to use sub-sterile are any really big open procedures, or a lot of orthopedic cases. They're really big about going in through the sub-sterile. When in doubt, ask a nurse, right? If you're in the OR and you walk in through the main doors, you're the only one there, do your thing. The moment somebody else walks in that door that looks like they have a clue what's going on, just ask them real quick. Hey, my name's Tucker, I'm a student anesthesiologist assistant. Can I ask you a quick question? Like, oh yeah, sure, do I need to come in, what doors do I need to come in and out of? They'll help you. They're really friendly, and they'd much rather you ask than mess up. And if you see somebody, if you ask and they say, oh, come in through sub-sterile, and then you watch someone else come in and out of the main doors, don't copy the person coming in and out of the main doors. Go through sub-sterile. I made that mistake and I got chewed out for it. So learn from my lesson, okay? Shoe covers, not typically mandatory, but they might help keep your shoes cleaner. I've only worn them one time. Eye protection, typically found in a common area, not within ORs. They're everywhere I've gone, it's been disposable. Personal choice, but it's one of those things where you don't know you need it until you've already needed it. So again, you'll figure that out with time. If you want to have them, it's not a bad idea to just go ahead and grab a pair and set them on like the anesthesia machine. That way you have them for later if you need them. For something like an orthopedic case and there's hammering, it only takes, one slip hit of the chisel, I don't know the tool name, and then now you got a speck of blood coming flying over the curtain. Or if they're irrigating, it could fly, catch that right angle like you're washing a spoon, and it comes and hits you. Personal choice. I've been thankful for it a few times, but I also don't generally wear it. So I'll leave it at that. So what should I bring? What should be in my pockets? So it goes without saying, but this is going to vary from location to location. And you'll get a pretty good feel for it, but what I do... Hang on one second. It is 8 a.m. I need caffeine. Stethoscope. I don't put it around my neck. I used to. I had enough people comment on it where I decided I was going to figure out another way. Some people get like the little hip holsters for it. I would always put it in my scrub pocket. So the scrubs that I've used, on my right leg, my right thigh, there's a big pocket there. I kind of coil up my stethoscope and just drop it in there. Out of sight, out of mind. It does catch on cords a couple times, but it's more out of the way. I keep a notebook with a pen, badge, my phone. You might get told not to bring your phone. You might get told to bring your phone. If you do bring your phone, don't get on it without asking first, and don't get on it for no good reason. I keep mine in my back pocket, so that way I sit on it, so I can't absent-mindedly just grab it. I have to like physically get up to grab it, so it kind of makes me less likely to grab it without thinking about it. Extra gloves, just like the latex gloves or nitrile, and then my watch. So, stethoscope, again, not around the neck. Notebook with a pen. I write down that stuff I talked about in terms of like base information about the patient. Don't write anything HIPAA, no names, no personal identifiers, no nothing. If you lose that notebook, you just compromised all of that HIPAA information. So don't get yourself in that situation, okay? I have heard a story of somebody doing that. Things ended well, but it was just don't let it happen. All right, simple as that. Just write down basic information. Where if I handed you that notebook in front of a stadium of people, you couldn't find them. Right? That's the easiest way I've found to think about HIPAA. Where if I handed you my notebook, you'd be like, oh, I have no idea who this is. But if it says, John Jones, you're like, oh, you get on the little announcer, oh, John Jones, he'll stand up. Right? Make sure that can't happen. And you can also, for the notebook, you can write down what you've done. Like, okay, I got an intubation, or okay, I got an IV. Badge, self-explanatory. Extra gloves, watch, self-explanatory. Alright, let me go ahead and... So the room setup. So, this is, again, another really subjective thing. It's going to vary by hospital, and it's going to vary by location within the hospital. Endo is different from main-OR, is different from bronch, is different from GI, different from EP, etc. So follow MS MAIDs, machine check, suction, monitors, airway, IV, drugs, special. Now, because it's your first day, you're not going to know what they normally get set up. They shouldn't get mad at you if you set up the basics. Here's what I mean by the basics, right? Endotracheal tube, oral airway, tongue depressor, tape, both for the eyes and for the tube, bite block, and laryngoscope. That's your base, right? That's your ground zero. Because the thing about each of those is if they get on to you and say, well, why did you get all that out? That can all also be classified as emergency equipment. If you're in a GI case, even if it's a simple colonoscopy, you might need that endotracheal tube. You might need that oral airway. You might need that tongue depressor, bite block, tape, laryngoscope. So at the very least, you have a solid foundational argument. I say argument's not the right word. You have a foundational reason for why you have all that stuff out. Because if you're doing a colonoscopy, patient goes apneic and you can't get them breathing again, you have all the tools you need right there, readily accessible. Now, if you start getting out 7 different LMAs and then 14 different eye gels and then a nasal airway and then you start getting out some crazy stuff, well, they might get onto you for it. If you don't know, probably just get it out and leave it in the packaging because you can always just throw it back and it's right there if you need it. So it proves you thought about it, but you were just trying to see what they wanted. But generally speaking, that I've got listed right there, that's your home base. Now, for an endotracheal tube, I mean like a prepared endotracheal tube, so like stylet, syringe, and then, have lubed the stylet. But that's going to be your base. Fluids, some places will want you to make them, some places won't. That's one of the things you can ask about. Generally speaking, it's just spiking a bag, running it through, getting all the air out. For drugs, I really recommend you do not draw anything up, even if you have the opportunity to. Because if you draw up something like Sugamidex right off the bat, you're like, oh, I know we'll need it. Yeah, if you end up not needing it, though, Sugamidex is expensive. And it's also kind of a bad look because they don't know how much you know, and it's this whole back and forth. The most I would do is get out the basic syringes, and I'd even honestly leave them in a package just to prove that you thought about it. On my very first days, I did not get out syringes because I didn't know what they expected. Each place has their own stuff. Some places, might lean on etomidate more than propofol. Some places are, the concentration of lidocaine might vary, so you need different sizes syringe. Some places have pre-made syringes. Some of them have pre-drawn drugs. Just, that's one of the ones where it's kind of permissible to just wait on your preceptor and talk to them. But the basic airway stuff and then basic fluids, you guys got that. No biggie. So pre-op and PACU handoff. So for day one, again, you don't know their pre-op routine. You might not even really know their location super well or how to figure out what bay the patient is in. To figure out what bay the patient's in, it's typically on the main OR board. So you can kind of use that, but you'll figure that out with time. Just if you do end up being asked to do it, just do the basic rundown, but do not do the 3-3-2 by actually holding your hand next to their face. It's gonna weird them out. It's more of an academic thing. I've never seen anybody do it in practice. Mentally go through it, but don't just start sticking your fingers there. So, an example of the basics, right? Just, introduce yourself, confirm the patient's identity, confirm the procedure. That's all the baselines. And just go through a simple top-down assessment. The way I do it is I literally just kind of go from the top down. Hey, have you ever had any a stroke, any seizures, or anything like that? No. Right, any issues with her heart, high blood pressure, ever had a heart attack, any AFib or any arrhythmias, any problems with your lungs, have you had asthma, COPD, no, kidneys, livers, those good, just kind of going through top down. Then towards the end, I'll go through the airway stuff. First thing I'll do is, I guess I should turn on my webcam for this. First thing I'll do is, all right, so any issues with neck mobility? So if you look all the way back, down, left, right, they'll kind of mime it with you. Any pain, numbness, tingling, anything like that. Some of them will say oh yeah, I can't go past here, or yeah, it hurts a little bit over here. And then I'll do the Mallampati check. So open your mouth, stick your tongue out, don't say I'll do it. And then I'll kind of take a look. So A, you're looking at Mallampati, but B, you're also looking at teeth and then airway opening. So you're looking at Mallampati, how far open they can get their mouth, and teeth. Those are the three main things. If they have a small mouth opening, that tells you that intubation might be difficult, fitting in an LMA might be difficult. Mallampati, again, that's just tissue density and such. And then teeth, so because they've already opened their mouth, you can kind of get an idea of what it's looking like. But the way I always do it is, all right, open your mouth. All right, perfect. Anything chipped, cracked, broken, removable, or loose in there. And, they'll say oh no, or yeah, this one's missing, or, whatever. If it is removable, go ahead and take it out, like dentures or whatever. Some people, it's a security issue for them. Not a security issue, but it's issue's not the right word. It's more of a comfort thing, where they don't want to part with it because it's part of their identity. It's kind of like taking out a prosthetic. Some people don't want to be seen without a leg, if that makes sense. So some people will ask, hey, can we wait to do that until we're rolling back? If they say that to you, defer to what your preceptor says. All right, you're not going to know how to handle that just yet, so defer to your preceptor. Or at the very least, if you're there by yourself, say, I'll go ask and check on that for you, and I'll get back to you when I hear back of an answer, okay? Just, so don't deflect, empathize with them, and go through that process. For PACU, they only care about a few things. So the general things they're going to care about, and again, day one, probably not going to fall too much on you. Name of the patient, allergies, a brief history, and I don't mean oh yeah, they had childhood asthma, or oh yeah, they broke their leg in 2012. I mean the heavy hitting stuff, yeah, they got high blood pressure, they had a coronary stent last year, stuff like that. What surgery they had performed, what you gave for nausea meds, what you gave for pain meds. Pain meds, also think about something like Versed. If you gave it up front, mention that. Muscle relaxant and reversals, yeah, we gave rock, reversed with Sugamidex. Ins and outs. So ins and outs being, yeah, we had to give blood. We gave albumin. This is his second bag of fluid. We got about 1,400 of LR going in. Outs is blood loss, urine output. Who the surgeon and anesthesiologist is. Basically, if something goes wrong, who do they call? And then anything crazy that happens. So if the patient had a really big, let me turn that off so you can read it. If the patient had a really big desaturation event, or if they had a heart attack, that's the type of stuff you need to mention. They don't care if you had to give labetalol. They really don't. Some places might want it, but generally speaking, it's not a big deal. And when you're done giving your report, just always end it with, hey, do you have any questions or anything I can do for you real quick? Because sometimes they might say, yeah, could you drop some more Zofran, or, oh yeah, what'd you do for this? Because maybe they read the chart and they'll go through it with you. But that's the basics. So here's what my speed would look like. And you're, all right, hey, this is John Doe, allergies to latex, relatively insignificant history, did have a stent placed in 2015. He just underwent a lap chole. We gave 8 of Decadron, 4 of Zofran, 2 of Versed up front. He got 75 mics of fentanyl on induction, and he got the last 25 right before he rolled out of here. Rocuronium reversed with Sugamadex. This is his second bag of fluids. Looks like we had about 1,200 total in. No Foley placed, and then minimal blood loss. Surgeon is Dr. Scalpel, and the anesthesiologist is Dr. Sleep. So, other than that, things went pretty straightforward. Do you have any questions for me or anything I can do for you? And that's just the full thing I'd run through. So, day 1, they're not expecting you to hit it out of the park. Just have an idea. So, during the day, be friendly, be willing to learn. If there is one anesthesia case, there is 10,000 different ways to go about doing it. So just learn what they're doing. I've had a preceptor who loves ketamine, and then the very next day I had a preceptor who hates ketamine. Figure out why. Don't be accusatory for it, right? So don't be, why'd you give ketamine? Go through it and, hey, was the ketamine for post-op pain, or is there something else going on that I didn't see? Go into it with that curiosity mindset. It's going to be overwhelming in the beginning. It's going to be scary. At least it was for me. That's normal. So just leave each day trying to have learned one trick and one fact. It will build up over time. Because after 10 times of being there, you've got 10 different little tricks and you've got 10 different little facts. And if you do have a preceptor who's kind of grilling you on something, you can write it in your little notebook too. If they want you to know, when should you not give Dilaudid? If you see this, do you give Dilaudid? Write that down. And that'll help over time. It'll also help their perception of you. So for like a simple trick, like how to bend a stylet in a tracheal tube, the way I was doing it for the SimLab mannequins was totally different than the way I do it now. So just, try to pick up the little things, and it'll come with time. Alright, let me hide this guy. So going home, when you leave depends on the cases, if there's add-ons, depends on the surgeon and the preceptor. It's one of the more variable things about this profession, at least in terms of being a student. So it's going to be easy to want to get out of there like, oh, it's, 2:30, I'm tired, I've been here since 6:30, I want to go. If you leave early, you're not going to be able to reach your hours, and you're not going to get as much experience. One day it is just going to be you in that OR, and you want to know what's going on, so if something bad happens, you know how to fix it. The only way you get that is with experience, and you need to build comfort as well. Now, if you have class, or you have a legitimate reason to leave, give your preceptor notification ahead of time, whenever it feels right, and give them an exact time. So if you have class at 2:30, don't leave at 2:30, because then you're going to be late to class, right? Go ahead and plan out when you need to be leaving, and just tell them, hey, I've got class at 2:30, need to be out of here at about 1:30, okay? And it's the easiest way to do it, because you might reach a stopping point at 12:45, and they'll say, "Oh yeah, we don't have anything else going on. Next case doesn't start till 2:30, so why don't you just go ahead and go?" Or they might, try to talk to you and go through stuff, but let them know ahead of time. And it's also kind of a bad look if you ask when you get to go home. Like if you just finished your second case, it's 11:30. Be like, "Hey, when do I get to go home?" Not a good look. So just take it at face value. And over time, you'll learn how to read the OR boards. You'll know the surgeons. You'll know the anesthesiologists, the CAA CRNAs. And you can kind of predict about when you're going to get to go home. Generally speaking, you will be home for dinner, though, at least as a student. Now, as a actual, once you're licensed, when you leave is up to the hours that you've picked. So, and yeah, if you have to get a preceptor eval, make sure you do that before you head out. And here are some little tricks. So, go ahead and practice tying that face mask. Now, you've all seen the ones that have the straps that go behind the ears, from the COVID days. From my understanding, those are not OR rated. They want you to have better ones, so you have to use the one with the ties. So, find one, buy them on Amazon and split them between your buddies. Just practice it. It's kind of a silly skill, but you have to tie a knot, up here behind your head and down here behind your neck. So, practice that skill, because otherwise, if it takes you 20 minutes to do that, it's 20 minutes you don't have anymore. It's a little thing that can go a long way. Know how to use your stethoscope. Make sure you point it correctly. Point it forward, not backwards. Know which side to use, and then stuff like if you want to listen to lungs, make sure they're ventilating, or make sure there's air going into the lungs when you're trying to listen. Otherwise, you're not going to hear it. And same thing for heart. Know general stuff. If you do get lost, you take a wrong turn, you don't know where you're at, no shame in asking somebody, "Hey, where are the ORs?" I've done it. No shame. Intubations, I always double glove, because if you get some spit on you, you automatically have to scissor their mouth open, so you're automatically going to have bodily fluids. And it's a lot easier to just shed that outer layer and then go and do what you need to do, rather than taking off the one pair you have and trying to put on another, and your hands are going to be clammy because you're nervous. Just double glove for intubations. Make sure if you're going to double glove, get relatively tight-fitting gloves. If you have loose gloves, you might rip them both off at the same time. So I'm kind of in between. I'm like a medium-large size. Mediums are tight, larges are too puffy. I just rock mediums. I deal with them being a little bit tight. So that's just what I do. You'll figure yourself out. Know how to spike IV bags, how to stopcocks, roller clamps work. Again, it might have been a while. Just make sure you know it. And you might have some weird stuff, like the Alaris ones, or the ones that have like 6 different stopcocks, or the blood bags and how there's 2 different things. So just know the basics. Drug math and doses. Go into the day you're going to obviously know how to calculate for rock, propofol, Versed, stuff like that. If a preceptor is about to give propofol, have an answer before they ask, how many mLs should I give? If you can't read their mind, but if it's a 100-kilo patient, what's the math behind propofol, right? It's about 2 milligrams per kilogram, 100-kilo patient, 200 milligrams, that's 20 mLs. So just have that in the back of your mind. If they ask, how much do I give? Oh, I would give this. And they'll either do it, or they won't, and they'll explain why. But have an answer for it so they can't stump you. Generally speaking, first day, they're going to push drugs for you because they don't want you to mess it up. Simple as that. Confirm doses and drugs. So if you're doing something and your preceptor says, "Hey, give some phenylephrine," you're like, "Okay," go grab it, make it, whatever you need to do. And then I'd hook it up and I'd turn to them and I'd be like, 100 mics of phenylephrine? And they'd say like, "Yep," or whatever, and I'd give it. And then that way it's a closed feedback. Because what can happen is I have heard of issues and I have seen issues where that communication can break down. And some drugs, for something like phenylephrine, there's a pretty clear delineation. 1 ml is 100 micrograms. if you have something like Zofran or Versed, probably more for the Zofran. You can get milliliters and the milligrams confused if you don't know the preceptor well. So always confirm the actual dose, like in terms of milligrams, micrograms, that you're going to give. Okay. If you want to give something, have a reason for it. So if you see the blood pressure and heart rate are tanking, oh, I need to get some ephedrine. And they ask, why are you giving ephedrine? Oh, it's because of the heart rate and blood pressure. Have a reason for it. Don't just blindly do it. You might know the reason, but if they don't know the reason, they're going to be more hesitant. So, and last and most certainly not least, just don't break the sterile field. Because you break that sterile field, you're going to have a bunch of angry people. It's not the end of the world. It does happen. Accidents happen. You're walking by and wind gust, whatever, right? But, so if you do break sterile field, let them know. But do your best to not. Don't want to make any enemies. So, yeah, that's everything I wish I knew before my very first day in the OR as a CAA student. I did have an anesthesia tech background, so I did have an idea of what was going on. But when you look at something through a different lens, it's totally different. So yeah, hopefully you found this video helpful. And feel free to comment if you have any questions or if you have any comments about, things I forgot or things I should have included. Just go ahead and let me know in the comments below. But other than that, I'll catch you guys in the next video. So have a good one.